So sexual assault and domestic violence, it's a public safety concern, and it took our legislative members, they actually had put out a legislative finding that because of the fear and stigma that often results from crimes of sexual assault or domestic violence, and because of the risk of retaliatory violence by the perpetrator, many victims hesitate to seek help, even when it is available at no cost to them. Without assurances that communications made while receiving assistance and overcoming the adverse effects of a sexual assault or domestic violence situation will be confidential and protected from disclosure. Victims will even be more reluctant to seek assistance or to confide openly to their advocates and to explore legal and social remedies fully. As a result, victims may fail to receive needed vital care and counseling, and thus lack the support, resources, and information necessary to recover from the crime, to report the crime, to assist in the prosecution of the crime, to participate effectively in the justice system, to achieve legal protections, and to prevent future sexual assaults and domestic violence. This is a matter of statewide concern, and the prevention of violence is for the protection of health, safety, and welfare of the public. So that's actually written in statute that you can find online. So we really have to do well screening our patients, and that's coming around from the computer, asking them like they're your friend, they're your family member, they're someone you care about. You don't have to read the scripted question on the screen. You just have to say, all right, do you feel safe at home? Is anyone hurting you or threatening you, making you feel afraid? And then that last question is, anyone making you do things you don't want to do? With human trafficking on the rise, we really are learning how we can help identify those patients, because when those patients come in, they're not going to identify themselves. Oftentimes, it's not what the media is portraying human trafficking as. It's not someone being picked up off the street and being thrown into sex trafficking. It's this person that's being groomed. It's a person that has the basic needs. Needs to feel loved, needs to feel accepted, needs shoes, needs clothes, needs food. Then this person swoops in and says, hey, I can provide that for you. And then they do. And then they tell them that they love them. And then now you owe me. And it's the debt that never ends. Excuse me. So oftentimes those patients aren't going to say, hey, I'm a human trafficking victim. They're just thinking that they got themselves into an unfortunate consequence or situation. So is anyone making you do things you don't want to do? Is there a debt that you're having a hard time paying off? And where did that come from? And then I think another thing that we do in healthcare is we ask the question, are you safe at home? We get a yes, we don't know what to do with it. Or we do something with it, but then it's not taken to the next visit, and we're asking again. And depending on how we ask that question is really going to affect how they answer it. Like, oh, you don't have the time for what I'm about ready to tell you because you're still behind your computer screen. Or I said yes before, why don't you remember now? And so just asking open-ended questions, and we'll talk about this too. I noticed that you stated you're in a domestic violence relationship at one point. Tell me more about that. And then that puts it on them. Do they want to talk right now? I'm fine now. Or, oh my gosh, and you might just get, you might have to spend some time with them because they might really open up. So why don't patients report, do you think? Fear, a lot of fear. Similar to human trafficking, we're going to see a lot of overlap in these power and control crimes. So domestic violence, sexual assault, human trafficking, strangulation. They've been beaten down by their perpetrator. You're not going to be able to do this alone. You need me. I'll take the kids, you'll never see the kids, you're not a fit parent. No one will believe you. I'll tell them that you did blah, blah, blah. There's always some kind of retaliatory mechanism behind them as to make them scared, to be fearful. They're unsure of their available resources. And then again, we're asked again and again and again. So just to clarify, in Nebraska, we all know the age of consent in most things, legal world, is 19. In domestic violence and sexual assault, we can treat a patient for physical and mental health needs at 18. We'll get into reporting later, but I just wanted to point that out, that the 18-year-old that comes in, we don't need to contact anyone to see them. So I also wanted to get us all on the same page of what we're talking about when we talk about sexual assault and domestic violence. So sexual assault in the legal world, first degree, is penetration. And that's oftentimes when we're called to court because of our patients to try to prove that there was penetration. And we see that The way we can do that is the swab from the vagina and around the cervix. I've gone to court before where they have asked me, or when we've been prepping, can you say that there is penetration? And I was like, well, what did the kit say? And they said, oh, well, we haven't run that. There's been a grant, so that's changing. Now every kit is sent, at least in Douglas County, to be tested at the state. So it might not be right away because it's the government and it's the state, but at least they're all being tested. The caveat to that is anonymous reporting. It's not tested. It sits on a shelf for 20 years should the patient decide that they want to report to law enforcement. That's because even if they got a hit in CODIS without a name, they can't put it in there to see if there was a match in the criminal database. So we need a name. So if you're anonymous and we don't have a name, it just simply can't be run. So second or third degree sexual assault, this would be contact. Person who subjects another person to sexual contact with or without the consent of the victim, who knew or should have known that the victim was physically or mentally incapable of resisting or praising the nature of his or her conduct. That's true for first degree or second and third degree. And that second point, B, would encompass alcohol, which is the #1 date rape drug that we see. So this YouTube video, I think it's worth our time to watch because I think we do a pretty good job of teaching our kids about human growth and anatomy and how they're going to grow and develop. But we really don't teach them well about consent and what that looks like and how you need consent through the entire act of a sexual contact and not just, before they started drinking or whatever. So Terry Perry actually showed me this video. Her son started Lincoln. He'll be a sophomore now. But they were showing this to all the incoming freshmen.
Only 1 in 3 Canadians fully understand what consent is. So Western, let's talk about it. Let's think about consent like a bike ride. If you wanted to go on a bike ride with someone, you'd say, hey, I'd like to go on a bike ride with you. And they'd be like, hey, I'd like to go on a bike ride with you. Boom. Put on your helmet, kid. You're going on a bike ride. You might hear things like, this feels great, or keep going. These are ways you know they're enjoying the bike ride. Maybe not those ones. If they said no, then that's that. They do not want to go on a bike ride with you. You don't toss them up on a bike and say, oh, come on, it'll be fun. No is no. And if they don't say anything at all, it's still a no. The absence of a yes is a no. They could say, heck yeah, or, I might want to. And you put on your biker shorts, get the bike, grab the helmets, and in that time, they decided that they don't want to and start to backpedal. And that's okay. They aren't obligated to go on that bike ride. You'll just have to bike on your own. Oh, and being dressed in bike shorts and a helmet doesn't automatically mean someone wants to ride a bike. It's quite presumptuous to think they do. Even if you happen to be in a relationship with your bike partner, you have to ask each and every time. Say your bike partner has had a couple of drinks, and we're not talking about water. They're not ready to go for a bike ride, even if they told you they are. A drunk yes is not a sober yes, and by law, you need a sober yes. Oh, and just because you bought them drinks all night, it does not entitle you to a bike ride with them. Same rules apply if they're unconscious. Unconscious people can't ride bikes, and they definitely can't say yes to doing so. The #1 priority is to make sure they're safe. Even if they're just sleeping, they can't say yes to a bike ride. And it can be a scary thing to wake up and find yourself on a bike. Imagine your boss telling someone, you can only work here if you bike with me to work. That's crossing the line. It would be an abuse of power for a boss or a person of influence to suggest such a thing. And just because someone wanted to go for a bike ride once, doesn't mean they'll want to every time. Maybe it was just a one-bike stand. You can't say, what are you talking about? We biked last night. You're simply not entitled to another bike ride if they don't want to. Maybe your fellow cyclist is totally cool with biking on paved roads. That does not mean that they are up for extreme mountain biking. You're not going to insist that they go speeding down a mountain with you if they are only interested in paved roads. That's uncomfortable territory, and you don't want to pressure your bike partner, do you? What if Alex here told you that Taylor really wants to ride bikes with you? Does that mean you throw Taylor up on a bike and say, all right, let's start pedaling? No. The only person that could say Taylor wants to go for a bike ride is Taylor. When all is said and done, riding a bike with someone should be fun, memorable, and hey, maybe a bit sweaty. But it can only be that way when everyone involved has willingly agreed to participate. So whether it's having sex or bike riding, consent is key.
So as you guys probably know too, just in society, we right away go to the victim. What was the victim doing? What was the victim wearing? What was the victim drinking? And so we really have to try to shift our thought process to the suspect. That victim did nothing wrong. She was just dressed as though she wanted to go on a bike ride, right? And it also helps us be on the same page with law enforcement. I can't tell you how many times, well, what do you think? Or did you say no? They'll come to the patient's room. Did you say no at all, ever? Or, so you said yes to vaginal sex, but you didn't want anal. That's extreme mountain biking, officer. And she didn't consent to that, right? So just trying to be on the same page, I think, of where and when you need consent, that it is throughout the entire process. And if you really do love this individual and want to be with this individual, you will know that you're consenting throughout the course of the act. So anonymous reporting came into effect last summer in 2018. So basically what happened is that as healthcare providers, if anyone comes in with physical injury sustained in the course of a crime, we have to report to law enforcement. The only caveat to that is the 18 and over sexual assault survivor. As long as they don't have serious bodily injury, which by state statute is pretty bad, and a deadly weapon was not used, they have the option of involving law enforcement, but still receiving medical care, still being able to collect evidence and turn that over to law enforcement without a name or any identifying information. And we found that that's really helpful, especially in small town Nebraska. I pick on West Point because I have friends there, and I was getting my hair done there at the time, and we were talking about sexual assault. She's like, well, we don't have any here. And I said, well, you just don't have any because they're not being reported because of the 5 officers, and you guys know everything about everybody. And so this law allows them to come to Methodist Women's to get medical care, evidence collected. We turn it over to Douglas County. So typically, we report to the jurisdiction where the crime occurred. In the anonymous reporting, we report to the jurisdiction where the consultation occurred. So OPD is going to get their kid, or Douglas County, depending on where they go, which one of our facilities they go to. And then they can take their time and decide whether or not they want to involve law enforcement. And maybe it's over not going to West Point, but going to the State Patrol and seeing if they'll be able to investigate it. So in our community in 2018, we had 403 rape reports by OPD. We saw 226 of those. And I think there's a lot of reasons. CHI did start a program, and their numbers are pretty impressive. So I think what that tells us prior to them is that they were going in and probably asking for help, and then them saying, okay, now you have to go to Methodist, and them giving up. Because truly these patients, when they ask for help, we need to help them. We need to help them where they're at, meet them where they're at. And so I think we're doing better for our community too. I'm hoping we see a majority of those patients in our facilities. So domestic violence, it's defined by state statute, relationships that may include spouses, former spouses, individuals who are cohabitating or have formerly cohabitated, current or past boyfriends, girlfriends, fiancés, and as well as persons for whom parenthood of a child is shared. I wanted to put this in here because there are still mandatory reporters for domestic violence. So no matter what their age is, if they have physical injuries, we still have to report to law enforcement. But what do you think those unintentional consequences are for those patients? Now we have law enforcement involved. Law enforcement shares their reports with CPS. Now their kids are involved. Now they're scared that their kids are going to be taken away. They're going to be being evaluated over and over again and trying to go through the CPS system. So oftentimes you'll see women who have children not actually come in for care of their physical injuries, knowing that law enforcement is going to be called. An example of this, OPD, these are the number of calls they took each year as a domestic, I'm sorry, that 2017 should be 17,000, I missed that, which is 3.5% of all of their 911 calls on average. So they're getting about 17,000 calls a year, domestic violence calls. Look at our numbers that we see, 100, maybe. So So those people, if they do have injuries, probably are not getting medical care of those injuries. And I would say not only just their physical injuries, but going beyond that in the mental health injuries and consequences, mental health consequences, truly. And us as medical providers needing to know that. So, for example, there was a woman who died at the hands of her partner. And so she did at one point say she was in a domestic violence relationship. Well, that's not carried over. So when she came into the hospital to our emergency room and said she was pushed down the stairs, we believed her and we didn't ask any more questions. And you have to wonder if we could have done better if that domestic violence question keeps coming over, and putting that in the forefront of our providers' minds so that we can ask the question, ask the open-ended question. Can you tell me more about your domestic violence relationship? And let them determine where that goes. And strangulation, I'm not afraid to tell our patients, strangulation is no different than someone holding a gun or knife to your head. It's just a matter of seconds before you can die. And each time they do that, you do have brain cell death, right? You're still having a consequence, even if you're not, 15 seconds you lose bladder control, 30 seconds you lose bowel. So even if you're not to that point, you're still having some brain cell death or anoxia. We always ask our patients, or we think oftentimes as a society, why don't they just leave? And we've kind of talked about that. Why don't they report? Very similar. But when they leave, that's actually the most lethal time. There's a stat, 41% receive medical care in the year prior to their death. Homicide is one of the leading causes of death for women aged less than or equal to 44 years, and rates vary by race and ethnicity. Nearly half of female victims are killed by a current or former intimate male partner. She says the worst question to ask someone that may be involved in a domestic violence situation is, why won't you leave? For me, it wasn't that easy. My abuser and I were together for 7 years. Only 4 of those years were my choice. We were inseparable in the beginning, and he made me feel as though we were a team. The abuse wasn't something that I considered abuse in the first few years. I was young and in love, so when he told me I shouldn't go to work because we needed to spend more time together, I found it flattering. When he told me to stop talking to certain people, I thought he was looking out for my best interest. And OPD's really, the Omaha Police Department has really taken this seriously. They've revamped their training for their new recruits and also their field officers that train them to really take domestic violence seriously. Their arrest rates have actually doubled in the past 3 years since they started that training. So I think that speaks volumes to them recognizing that this is a problem and wanting to do something about it. So I want to talk a little bit about the neurobiology of trauma, and this has kind of become a big interest and talked about a lot in our forensic nursing world. But if you think of your brain as your palm, your thumb is kind of your midbrain, or your more primitive brain, we'll say. Your amygdala is there, your hippocampus. And I love, Russell Strand will talk about, he says, if there was a hippo on campus, you would remember. That's where your memory is stored, right? And that's where your freeze, flight, or flee response is going to be. So then wrapped around your thumb, your fingers, your prefrontal cortex, your more executive functioning, and that's where you're going to put things in order. So Rebecca Campbell, she's a sociologist. She's done a lot of research on how we respond to trauma and then also how police can better respond to that. And she'll say that when we're not in trauma, we have Post-it notes, line, big, small. They're in order, and I can tell a story from beginning to end in great detail by pulling those. She says after trauma, you just have those small little Post-it notes with little pieces of information, and they're scattered. And so as you tell your story, it might not make sense. It might not be chronological. And then you're at this Post-it note, and you're interrupted, and you might skip the next one, not to be found out for later, for much later. You might not remember for a while. So the best thing we can do is let our patients speak. Tell me what happened to you, and just let them go. Ask clarification at the end. And then Russell Strand, I think, is really interesting. He was a police officer in the military, did a lot of investigations. His line of questioning was always start from the beginning, leave out no details, try to get their story, who, what, when, where, why. But then he started doing debriefings after mass casualties, and he found the way you ask questions after a mass casualty, also victims, got much better, much more information than the typical law enforcement. Tell me what happened to you, start from beginning to end, leave out no details. And so he started training and trying these things out with his victims, getting more information. So what he'll say is, what are you able to tell me about your experience, and let them go. Kind of go back to the Rebecca Campbell, don't interrupt them, let them speak. Tell me more about, do you need to clarify something? Because oftentimes, as you know, people have different words for their genital area or sexual acts. So tell me more about whatever. Help me understand what you meant by whatever. What were you feeling when this was happening? What was your thought process during this experience? And then we always go to the senses. Do you remember seeing anything, smelling anything, tasting anything? And sometimes, our patients have out-of-body experiences, and I'll say sometimes when this is happening in our body, we focus on something in the room. And one patient said, oh my gosh, the purple polka dot sheets. I'm like, go tell the law enforcement officer, purple polka dot sheets. And so hopefully they can go find the purple polka dot sheets. It's much more of them living the story and recounting the event rather than trying to answer the who, what, where, when, why. And I think one of the most important questions we can ask our patients is, what can't you forget about your experience? Most times, something's in their brain. They're ruminating over something that they're having a hard time letting go. And if we can help them work through that, making sure we reinforce that what happened to them is not their fault. No matter how much you drank, no matter what you did, what happened to you is not your fault. We can really help try to prevent them from getting PTSD if we can help them work through those thoughts. So tell me what happened from beginning to end, leave out no details. Because what happens is that the law enforcement then, the story doesn't make sense. Something's wrong in their chronological order that they just told their story, and what did they do? They pounce on that information. Well, how could that have happened there when you just said this? And then they get more nervous, and then they're more, oh, he doesn't believe me, and then it's just a downward spiral from there. And stay away from the 5 Ws. So when we're charting, if you come across a patient and you need to chart something on them, we're trying to change the narrative here. I would love, as an institution as a whole, a patient doesn't refuse anything. As your body being your vessel, I should be able to decline anything that someone thinks is right for me, even though it could be right for me. But I think we should be able to decline something rather than refusing, because it just seems like I'm trying to be malicious almost. We're getting away from alleged sexual assault. Sometimes we would see people come into the ER and we'd see alleged. People don't allege a headache, so we're not going to allege a sexual assault. Victim admits, confesses. Just victim states. That's their truth. That's what they say happened to them, so it's victim states. Victim is unharmed. That's a big jump for us to say. Visibly unharmed, potentially, but definitely not unharmed. And never ask if they said no. So I think another thing I want to touch on, suicide is much higher in especially sexual assault victims, depression, as you can imagine, in domestic violence and sexual assault, and then PTSD. So when our patients come in to the emergency room and triage, we really want to make sure that we're asking, have you been strangled? Have you been struck? Are you bleeding? And have you had thoughts of hurting yourself? So the sexual assault nurse is called in when the patient presents. Their medical needs are obviously first and foremost for us. The nice thing about our role is that there's a medical hearsay exception in court, meaning when patients come in, they should tell us what happened to them because it's going to affect their care and inevitably their outcomes. So that's why we're helpful when we get the history of assault, knowing that that's going to guide not only our medical care but also our evidence collection. We do a safety assessment at home. We obviously don't want to send them back to a horrible situation. If that's where they want to go as a domestic violence survivor, then that's where they can go. But the WCA is really good about helping them get out of their lease, helping them find a place to stay in the short term, and then hopefully in the long term as well. We do a RIO systems, physical assessment, injury identification and documentation, and that's important so that we can say this was an injury versus normal anatomy. We'd like them to follow up at the Methodist Community Health Clinic. We offer their first follow-up exam completely free so that we can reevaluate those injuries. And as you know, bruising doesn't necessarily happen right away. We can assess the bruising later and then also say, okay, that injury that I thought was there is still there. Maybe it's normal anatomy and not an injury, or vice versa. It's in a healing process. And so that's good, especially in court later. Collect evidence and then provide medication prophylaxis. So the sexual assault kit was actually changed 2 years ago. We used to pull head hair, and there's more research coming out that might be more beneficial, but you have to have the root of both hairs. So the hair that I pull from the victim and then the hair at the scene to be able to say it is a for sure match. Otherwise, they could look and say that it's the same color and consistency, texture of the hair, but it wouldn't be definitive without the root. So how often are the police going to go find a hair? It's not very often. And then where are sexual assaults taking place? Where you're supposed to be. So your bed, your car. So it just wasn't helpful, and it was more trauma than it was worth. So they got rid of that. And then we used to send a wet prep down to our lab looking for sperm. More often than not, we would get a, hey, we didn't see any sperm, but we saw trichomonas. And while there are rape shield laws, we don't want that to get in the way. But more importantly, we thought it was misleading for law enforcement where they say, oh, there wasn't semen in this sample, so therefore there wasn't penetration. Well, what if a condom was used? What if they had a vasectomy? So many other things. So anyway, got rid of it. Now what it looks like is this foreign material sheet. We put it on the floor on top of a sheet so that the dirt from the floor doesn't get on the sheet. They get undressed and hand us each piece of clothing one by one with the idea that any kind of debris would fall on that sheet. Lab also has said that they have never run that, but what could be helpful, I had a patient one time who was sitting outside the bar waiting for her friends to be done. Car pulled up, had a ticker, looked like a cab. He said, hey, do you need a ride? She said, yeah, but I'm waiting for my friends. I don't have any money. He said, that's okay, this one's on me, I can take you home. She gets in the cab, she goes down, he takes her downtown somewhere and there's a field, and he rapes her and follows her as she's trying, she promised that she won't call 911, she was just trying to get a ride, follows her as she's using her phone to make sure she's not calling 911, ends up attacking her, taking her phone, and he said, that's what you get. And she was like, that's what I get. Long story short, should we have collected the foreign material sheet, the dirt from that field could have, if we needed to, put her at the scene. So clothing and underwear, we have two things for underwear now. So if the underwear that they come in with, and then if they brought the underwear they were wearing at the time. Sometimes those are the one and the same, but it's nice to have more bags for underwear. And then also clothing. We only had 2 bags prior, and now we have like 4 because we layer in Nebraska. So oral swabs, this would be looking for a cross or a mix of DNA from the victim and the perpetrator. We do fingernail swabs around their nails. DNA testing is so sensitive that we can sometimes now, like in a strangulation with hands, get some swabs from their neck and potentially get skin cells, skin transfer from the perpetrator. So we've been doing that as well. And same thing, if the victim is holding the perpetrator, we could potentially get skin from them. Additional ALS swabs, we swab by history. So if the patient says that they were licked, kissed, bit somewhere, we'll swab those areas. And then we also use an alternative light source, which is a blue light, looking for bodily fluid glow, swabbing those areas. Some research did come out that said we could see bruising below the skin with that alternative light source. We haven't been as lucky as the research has said we should be. The room has to be dark. You have to have kind of the perfect scenario for it to show up. But then you run into, okay, you go to court and you said that you saw something below their skin, and how are you truly able to say 100% that that's what it was? So we kind of ran into that. We recently, a year ago, invested in the Cortexflow camera system, which has a contrast filter for us. And so we've been really lucky to be able to highlight injury that's there. So we might see, for example, there's one picture where I saw a red spot on their neck, and then you put on the contrast filter and you could see 4 other dots. So probably consistent with their story of, or their history of being strangled with fingers. Then we do a mons pubis swab. That's anywhere where you have pubic hair, looking for foreign pubic hair, and then any kind of body fluid transfer. We inspect and then swab the external genitalia, do a speculum exam, do vaginal swabs, and then also anal. Even if they say that they weren't anally penetrated, oftentimes, if we're there, we're going to swab the anus just because of gravity. And then they're able to shower, brush their teeth, use mouthwash, and we swab their mouth for their DNA profile now. In the past, we'd poke their finger kind of like a glucose stick or sugar stick, but now we can just swab inside their mouth. So it's not quite as invasive for the patient, which is nice. And then medications will boost their tetanus, provide hepatitis B if they need it, nausea prophylaxis. STDs, we don't test, we just treat. Most of the time when our patients come in, they're in that incubation period where that test is going to be a false positive or a false negative. So we're just going to treat them. Then it's something else that they don't have to worry about once they leave our facility. Caveat to that, because of alcohol, oftentimes that flagyl will go home as a prescription. And then pregnancy, if they want to try to prevent pregnancy, and then HIV. HIV is hard, and especially you social workers have probably been asked for foundation dollars to cover that. But the Walgreens specialty pharmacy, to keep in your back pocket if you ever run across this, which is just right here by the McDonald's on 77th and Dodge, they're able to get those HIV meds at low to no cost for our patients. So this $2,000 month-long treatment oftentimes is $0 for them with the magic and grants that they have available. So other resources, we found when we started the program, in 2003, that if you ask the patient, hey, we have these advocates that come in and help you, would you like me to call them in? And what's the patient going to say? No, I'm fine. So they're activated when the Sane nurse is activated. They're at the door. We say, hey, an advocate's here. Is it okay if they come in? And 99% of the time, they say, sure. And I can't stress that enough for their well-being after they leave the hospital, because I always say we don't heal them when they walk out our doors. They still have a long process to go and probably lifelong consequences. So they have group therapy or support groups, counseling. They have legal help if they need help with protection orders. There's 3 protection orders now. There used to just be harassment and then just the domestic violence protection order. Now there's also a sexual assault protection order. That one's being fought more and more in court, though. So the perpetrator is coming to court to fight the protection order, because if you get the protection order, then there's probably a little bit more guilt should you go to court for the actual sexual assault. So those seem to be going to court more than just being granted. And then a law just passed that instead of the judges having the protection orders come across their desk and not granting them, now if they're not going to grant them, they actually do have to go through hearings, so the victim can get up and say exactly what they've been through. So I think that'll be a win for our victims. I talked really fast. Do you guys have any questions? Yeah.
So I always assumed that, when we're mandatory reporters and we're treating an injury as a result of domestic violence,
Mm-hmm.
I always assumed the sexual assault would be under that umbrella, but what you're saying is it wasn't, and only up until a year ago now we have to report it?
So up until a year ago, you had to report everything, sexual assault or DV. And then a year ago it changed. Sexual assault is a caveat. And as long as they don't have serious bodily injury, state statutes like loss of life or limb, organ, concussions are not considered that, which hopefully we can change. Our legal department says that if they are strangled, we should report, since that is a felony. So that's serious bodily injury. But otherwise, I think that's where I get the most hung up on the concussions, like what we know about concussions in football players, and probably this is happening over and over again to these victims, that doesn't meet the standard of serious bodily injury. So choked would be food inside, and then strangled on the outside. And then I think a lot of misunderstanding in the community is that it's occluding the trachea, and it takes less pressure to occlude the jugular and the carotid. And that pressure, when they occlude that, is what's going to cause the petechiae, the burst of those small vessels. So that's why we're looking under the eyes. If by chance they were able to occlude both at the same time, you're not going to have that pressure change, and so you might not have petechiae. And because it doesn't take much pressure, you might not see fingers on their neck. And so that's why it's so hard to prosecute, because it's such a silent killer. Dr. Smock does a lot of research on strangulation. He says there's actually 25 potential consequences of strangulation. Oftentimes, many of those are because of the shearing of the vessels, or maybe throwing a clot. It's all oftentimes stroke-related, an aneurysm that could potentially burst months, years later, but that could have actually started when they were strangled. And then obviously airway swelling, any kind of fractures in any of the bones or cartilage in your neck. Obviously has some detrimental effects. And then a thyroid storm because they squeeze the thyroid. So 25 consequences. The recommendation is that if they've lost bowel, bladder, or consciousness, that we do a CTA of their head and neck to evaluate to make sure they don't have any consequences that we can see right away. And then, actually, one other thing I was going to mention, prior to this last legislative session too, suffocation wasn't on that bill or wasn't on that law. So they were having a hard time also prosecuting suffocation. So we went and testified on that, and it passed. So now suffocation and strangulation are on the same bill with felony consequences. So, yeah.
I just wanted to clarify on the ambulatory reporting, that's if they're seeking care for injuries related to...
Yep. And the law specifically says physical injuries. So,
I mean, I work here at the cancer center. You know, we'll go down and talk to people who indicated they don't feel safe or thinking, and talk to them about resources or if they're wanting to do anything.
yeah. Yep.
They're here for other...
Yes. And we just put a PowerPoint presentation together to email out to all the clinics. I don't know if you got it too, to kind of clarify, to call the social work. You guys do a great job for those patients that they don't have injuries for us to document, but they just need the resources. But we do have 911 phones if you ever need to use those. There are donated phones that the YWCA or the WCA gives us that can call 911. Because oftentimes the perpetrators take control over their phones, right? So they're not able to call 911.
So to give out to patients?
If they're in that situation where they're scared and they just want to back up in case the perpetrator.
Call you?
Yeah, or the ED. They should know where they're at. It's a good resource. Yeah.
So I do behavioral health in ED,
Awesome.
and there's certainly a decent amount of people that come in for sexual assault, and then we get called to assess them.
Mm-hmm.
And I always feel I have a hard time with those assessments because it's just, you know, they're in such a vulnerable place, and how much information do I try to get from my assessment, but then still being respectful of what they've been through? And
Sure.
do you have any advice on that?
No, I think whatever they're willing to tell you and whatever you can document is good. I think all the reports.
I don't push anything.
Yeah.
Because it's like they've already been through it. By the time they get to me, you know.
Yeah, and I think that goes back to meeting where they're at. Like, what do you need from me? And then you guys just have a hard job too assessing a lot of their needs too.
Trauma there.
Yes.
That the way that they're feeling is pretty natural.
Yeah.
You know, I mean, so trying to, I think it makes it so much more challenging to determine how safe they are in those moments because they've been through such a terrible thing that it's challenging.
I believe. Yeah, I could. It's nice for us when we're like, oh, good, behavioral health is coming in to help us, because that is. I can only imagine with your work how that would be hard to navigate. But I don't think you need to be scared of staying away from the story of what happened to them, and documenting with quotes, which you guys are always good at. I wish I had a better answer.
I know it's tough. It's one of those that I've been doing behavioral health now for like 3 years, I think, and it's one of my biggest struggles when I have those calls because, well, one, it's usually women, and as a woman too, I picture myself in that position. It's like, it's just one more person that I'm, we're having to spill this whole terrible ordeal to.
Yeah. And I think there's 2 lines of thought on that too. Like, one, we used to say, we only want them to tell it 1 or 2 times. Give them a sleep cycle before they see the investigator. But I think some victims will say, the more times I talked about it, the better I felt, being able to get it off their chest. So it kind of depends on the victim. Yeah. Any other questions? Thoughts? Yes. So we say 13, but for females, we'll see anyone who has started their menses or puberty. Because there's a difference there's a pediatric certification and adolescent adult, and so the adolescent adult falls under us, and then the pediatric falls under Project Harmony. In the past, Project Harmony, if they had a kiddo in that situation, they would do the forensic interview, they would call us with report, and then send the patient to us for evidence collection. That's also a lot for the patient too, which we really valued that they trusted us with their patients, but recognizing that it was a barrier and just took more time, they started seeing adolescents at the beginning of July. So, but if the patient were to start here, we would do the forensic interview, we would do the whole thing, and then they would go to Project Harmony for the forensic interview piece. Project Harmony is really good because they will video record it so the kiddo doesn't have to go to court. Their forensic nurses or forensic interviewers are trained so that they're not leading the child. They have body diagrams in the room so the patient can point to where their body was touched, how it made them feel, that sort of thing. So, yeah.
So if they're like a teenager,
Mm-hmm.
then they just stay here and we don't send them?
Correct. Yep. And then law enforcement most times will schedule a forensic interview there since we are not trained, aren't recorded, should they want that for court.
Yeah, I guess just that piece. 11-year-old versus a 13-year-old.
Yes. Yep. Children aren't as urgent. I would say their evidence collection isn't as urgent as an adult. We have, and actually smaller window, 72 hours for kids, 120 for adults. But Project Harmony wants to make sure that they're in a good place. So oftentimes they're going home first before they're going to Project Harmony for the forensic interview. Or parents are bringing them from Project Harmony's forensic interview to our hospital. Since it's not a medical facility, there isn't an EMTALA issue. It's just asking them to go. But that won't happen any longer. Most times it shouldn't happen. Where they do the forensic interview and send to us, they should just be doing the whole thing now. Yeah. Anything else? Awesome. Well, thanks for coming, you guys, and listening. I'm always available if you have any issues that come up.